This is Sally Schessler, the Director of Education for Allergy and Asthma Network, and welcome to our 2017 webinar series titled Advances in Allergy and Asthma. Our webinars are also brought to you by the American College of Allergy, Asthma, and Immunology. The goal of our webinar series is to share guidelines-based information and resources with you that are relevant to your life and your practice. This series helps Allergy and Asthma Network live out our mission to end the needless death and suffering due to asthma, allergies, and related conditions through outreach, education, advocacy, and research. This webinar is titled Taking Control of Your Eczema, and we're joined today by Dr. John Lee. Dr. Lee is a pediatric allergist at Boston's Children's Hospital. He received his medical degree at NYU School of Medicine. He completed his internship at Children's Hospital of Philadelphia and his residency at Columbia Presbyterian Medical Center, Children's Hospital of New York. He completed his Allergy and Immunology Fellowship at Boston Children's Hospital. He is board certified in pediatrics and allergy and immunology. Dr. Lee is an instructor at Harvard Medical School and is the clinical director of the Food Allergy Program and allergy director of the Eosinophilic Gastrointestinal Diseases Program at Boston Children's Hospital. He is also an associate attending for the Aerodigestive Diseases Program. He is currently involved in research investigating oral and epicutaneous peanut desensitizations and treatments for eosinophilic esophagitis. He is also the co-founder of AllergyHome.org, an online resource dedicated to educating the community about food allergies. Allergy Home has created a free anaphylaxis web-based module that has been viewed over 100,000 times. It is used to assist school nurses in training school staff on management of food allergy and life-threatening reactions. We are so pleased that Dr. Lee is an anaphylaxis community expert volunteer for the Allergy and Asthma Network. He served as medical expert for the American Academy of Pediatrics Asthma, Allergies, and Anaphylaxis Champions Program. He has been selected as a Best Doctor of Boston for allergy and asthma. He has given talks nationally on food allergies, anaphylaxis, and eosinophilic esophagitis. He has also lectured on atopic dermatitis at the New England Dermatology Society and the Society of Pediatric Dermatology annual meetings. Well, it's now time to start to take control of our eczema. Dr. Lee?
Wow. Well, thank you, Sally, for that introduction. I've actually known Sally for a while, back when she was working with the National Association of School Nurses, and she really has been so great about educating and raising awareness. So when she asked me to do this webinar, I couldn't say no to her. So I'm really honored to be part of this webinar series. Anyway, so I'll be talking to you today about taking control of your eczema. And I'm really excited about this topic because this is something that I see for most families in my clinic, that there's usually something more that I can do to help with their eczema. I mean, the problem is that there's so much information to share that it really can be hard to cover in a single office visit. But I wanted to start by talking about what is eczema. So really, what does it mean for you? So anyone who knows about eczema or lives with eczema, they're familiar with that dry, scaly skin or these red inflamed patches that get broken down, have that crusting, the oozing, or that intense itching. But what I wanted to start here with is really, what does it mean for you or family? So how does it affect children or adults or parents who have to cope with this on a daily basis? Really, how does it feel like to have eczema? And so first, for many, there can be these issues with feeling self-conscious. So some may have severe symptoms that actually make them shy away from interactions with others. So they may not want to participate in some activities where they, particularly ones that may reveal more of their skin, such as in swimming. They can also have some experiences with bullying or being made fun of. There actually are studies that show that kids with eczema, 1 out of 5 of them actually have some experience of being bullied. It can also be more subtle than that, so that they can have those looks or stares from others about their skin, or comments or questions like, what's wrong with your skin? So all this really can affect how people view themselves. There was a survey of teens who've had moderate and severe eczema, and it showed that 1/3 of them did report that their eczema did have an effect on their self-confidence. Also, families can feel exhausted. So this comes from the lack of sleep or that restful sleep. So if a child is itching and scratching all night long, he's not going to have that restful sleep, that restorative sleep that you need. And in the morning, they won't feel well rested. And if a child is waking up multiple times through the night, we know that that means that parents aren't going to be sleeping as well either. So this exhaustion definitely is not going to lead to a happy household. There's also going to be blame, and it can go in a couple of directions. So parents can blame their kids for not doing their jobs in managing their eczema. They may think that only if you just listen to me or allow me to put on this cream, then things would get better. Even doctors can be involved in this. So what do we call patients who don't follow our recommendations? Non-compliant, right? And this is a way of saying it's not our fault that the patient isn't getting better. They're not really following our recommendations. But sometimes as doctors, we don't appreciate the dynamics that may be at play at home, or don't understand any of the all the obstacles to implementing therapy. So some families may not have the time to do these things. They may be too expensive, the prescriptions that we write for them. Maybe it can be something as simple as really not having a bathtub to do the baths that we recommend. Blame can also be directed inwards. I've seen this with a number of parents in my clinics where they're wondering, what did I do to cause this? Was it something I ate when I was pregnant, or something exposed to them when they're younger, or was it just my genes and my allergies that really cause my kids to have eczema? Anger can also be experienced, and this is typically expressed by older kids. They can feel it's unfair, thinking, what did I do to deserve this? They can also have fights with parents because they don't want to comply with these regimens of the ointments and the moisturizers. They can't stop scratching, and they don't want to take those baths. So anger and frustration definitely is a component. And then there's denial. So this can actually be surprising at times. So I've seen kids who've come into my clinic with this red, irritated, raw skin. They're scratching away. They're really not looking good. And then so I ask the families, how are they doing? And they can say things like, oh, little Johnny's doing great. We're so happy with how things are. And so part of this can be that they just may be living with it so long that this has become their new baseline, and they don't feel that they really need to step up in therapy, and they don't realize that their skin can get under better control. And then there's despair. So a feeling of despair actually is not that uncommon among families and patients. So there was that survey of teens with moderate to severe eczema, and more than a quarter of them had felt helpless during a flare, and half of them reported feeling unhappy or depressed. So it's a sense that things won't get better, or an uncertainty of where to go or what to do from here. Now, if any of this sounds familiar, then you have an idea of really what eczema is, and you know that it's more than just a medical condition. It has far-reaching effects on your emotional well-being, your quality of life, your self-image. So actually at our center, we have this multidisciplinary atopic dermatitis center, which includes a child psychologist who's really an integral part of this team to treat kids with AD. And so what I want to tell you is that really there is going to be a light at this end of this tunnel. Things can and will get better for you and for your families. So most patients that I see do come in confused, not sure what advice to listen to. They don't know really where to begin to manage their eczema. And so for the most part, although the eczema can affect their lives in very deep ways, we can actually help them in pretty fairly straightforward ways with very simple recommendations. So if you have this, then you know that there's ways that we can take control of your eczema. And so for this talk, I wanted to have some pictures of before and after therapy. So this was a patient I saw a few months ago, a fairly typical baby. He was 5 months old with eczema. I characterize it somewhere between mild and moderate, really not too severe. But you can see his cheeks. You see that red, irritated look to it. There was oozing and crust forming over it. That picture of his abdomen is maybe a little bit harder to appreciate, but you can see that there's this very dry feel to it. There's some excoriations from the scratching, this overall redness. And because of that scratching, parents who were sleeping very poorly, they were really distressed to see that their beautiful baby skins was really being affected like this. And they were using a mild cortisone ointment, which really wasn't helping them that much, but they were afraid to use anything stronger, and they didn't know what else to do. So in that visit, provided some education, laid out a plan for them, and then so with a number of interventions, they came back in 2 weeks' time, and really his skin had really gotten much better. Although this is probably a milder, moderate case, like I say, that for most families and patients who are living with eczema, there's usually room for improvement. Now, one thing that people ask is, what's the secret? What's a magical cure that can really help with this? Their families often ask, what cream should I use, what food or what clothing will help really clear this off? But the problem is, and the truth of the matter is, there isn't any easy answer for this. It is a struggle that families and the children need to work together with, and with really the right support and tools, they can really gain the upper hand. So the goals of this talk. So first I want to start off with some basic biology about skin and eczema, then talk about the key components of eczema care, and then go on to talk a little bit about some of the common misconceptions about food allergies and eczema, and then finish off with really talking about this rationale for this early peanut introduction that's really been introduced in the last month or two. So first, the biology of the eczema. So this is a diagram model of our outermost layer of skin called a stratum corneum. It's this brick and mortar type of hypothesis or theory, so that the corneocytes, the cells, are these bricks, and the mortar is the ceramides or lipids that really cement things together. And so what it does is it works together to form a tight barrier, and this really is a critical barrier that helps protect our body from any type of insults externally. Now, what happens with eczema is that the corneocytes can be disordered and get broken down. The lipids can be decreased and go away, and so that with this there are some breaks in this barrier. And one of the consequences of this is something called transepidermal water loss. And so we know that in kids who have eczema, this water loss occurs much more rapidly than in kids who have healthy skin. And so this can contribute to the drying that we see. That's really a typical feature of eczema. Then also with this barrier defect, then we can also see that this can lead to infiltration of bacteria, viruses, and allergens into the skin. And this can also trigger inflammation, which then sets off an eczema flare. Now keep in mind the stratum corneum is really very, very thin, so it's only several layers thick. And so this is equal to about 10 to 40 microns, which is about 4/100th of a millimeter, so very, very thin. And so you can imagine how easy this is to get broken down if you're scratching or have some inflammation in there. And so there are studies that actually showed the importance of really maintaining this barrier, and actually there was one that's talked about prevention of eczema in infants. They've studied infants who are at risk for developing atopic dermatitis, so that meant that they had a first-degree relative with a history of eczema. And then they really just had a group that had a very simple intervention of applying a daily moisturizer beginning in the newborn period, and compared them to a group of newborns who didn't have any type of moisturizer, and they followed them over time to see about the development of eczema. And what was found in these studies is actually that just by doing that one simple intervention, they were able to decrease the risk of developing eczema by 1/3 to 1/2. So this theory was really that this daily emollient really can help repair the skin barrier, prevent water loss infiltration, and ultimately help prevent the development of eczema. So here is my concept of how to manage eczema. And the ideas presented here aren't that new, but they really are sort of the basic concept of management of eczema that's been really talked about for a while. And if you hear physicians give a talk, they may say it in different ways or break it down into different types of categories, but really at the core, we're really all talking about the same approach. So in this, my version, I talk about the 3 I's of eczema: the itch, the inflammation, and infection. And these are all factors that we really need to address. And I really like this image because each of these concepts are interconnected. They really don't stand alone. So you can't control one without controlling the other components. Now, it may seem obvious to some physicians or families, but one thing is that I've seen people forget to really look at these principles when you're talking about eczema care. You really do need an integrative, comprehensive approach. So in regards to this, I mean, there is one factor that really is important that can help with all of these. It's moisturize, moisturize, moisturize. And so if there's one thing that you take away from this, this is this key concept. It's really a first essential step in taking control of your eczema. So this is an analogy that can be helpful. So imagine that this is skin for those with eczema. It's really this ground that's made of this dry, cracked clay. So when it rains, yes, the ground gets soft and wet, but what happens when the sun comes out? It's going to come out, it's going to bake the ground, and all the water that had seeped in is going to evaporate again, and your ground is going to be dry again. So how do we prevent this? So after the water seeps into the ground, we need to find a way to seal in that moisture so it doesn't escape again. And so that's where moisturizers come into play. So their role is to seal in the water that had soaked into our skin to prevent it from going out again and from evaporating. These emollients can also help provide a barrier to help prevent allergens and bacteria to gain a foothold. And really, again, all this helps restore our natural barrier. With the idea that we need these moisturizers, so which one is best? And this is really a hard question. If you go to your local pharmacy, you're going to see on the moisturizer aisle, you're going to see literally hundreds of different types of ones to use. And so families come in all the time asking, which one is the one to use, or they come in with different brands of moisturizers that they use for their kids. It's really hard to keep track. But the answer is really a trick question. It's really, it's one that you will use. So if you or your child or your patient really complains that their moisturizer is burning and stinging when they apply it, or they don't really like how it feels because it's very greasy, then they're not going to use it. And so if it's not going to be used, it doesn't really matter how highly recommended it is. But now I say that there are some asterisks to this statement. So first, there are some things I do prefer. To avoid perfumes or anything that can be a sensitizer or irritant that can really actually trigger and make the eczema worse. Also, moisturizers that contain alcohols can tend to be more drying, and that actually can be counterproductive when you're trying to manage your eczema. Also, there's going to be essentially 3 different categories of moisturizers: ointments, creams, and lotions. And the differences between these is amount of water content, where ointment has no water in it and lotions have high water content. And the issues then is that with lotions that have this high water, when you put it on your skin, it can make you feel soft for a short period of time, but as the water evaporates, it's going to lose that barrier and actually can end up causing your skin to become drier again. So that in general, I do prefer ointments and creams if possible, where ointments, though, tend to be less well tolerated because of that greasy, prickly feel sensation that some people complain of. So in some families, I suggest perhaps a compromise where you use a lighter cream during the daytime, but then at nighttime you try putting on a thicker ointment. And our psychologist in our AD Center, Jennifer Lebovich, actually has had some suggestions for families on how to make this more tolerable. So she's talked about really involving kids in part of the process as much as they can. So have them put it on wherever they can for themselves. They can even start by practicing by putting it on a small stuffed animal so they can see that it really isn't that bad of a thing to do. They can also try drawing pictures or words with the ointment on their skin and then rub it in. And then if the kids or your kids are really competitive, you can time them and see how fast they can put it on and see if they can beat their time from the last time around. Another question that comes up often is how often you should bathe. And this is something I hear different advice from anywhere from once a day, twice a day, to no more than once a week. And the argument for less bathing is that it can wash off these natural oils and can cause the skin to become more dry. And then the cleansers that are used are harsh and can actually make the skin worse. And what we know is that doctors definitely have contributed to this confusion with their differing recommendations. So this was a survey done looking at different physicians and the advice they give. And you can see that primary care physicians recommend daily bathing 21% time, allergists 57%, and dermatologists 71% of time. But it really does seem that overall the consensus, at least from the specialists, is moving towards more frequent bathing, that's daily baths. And this is also reflected in this new joint guidance from allergists and dermatologists to pediatricians that recommends daily baths. But it should be done really in a very specific way. And it's really called the silk or seal method. So you should use lukewarm bath water. So very hot water can actually end up causing the skin to sweat more and cause more itching and inflammation. So lukewarm is best. Have the person sit in a tub for 15 minutes so it can really soak in there. No cleansers no cleansers are really needed for kids, or you can use a gentle cleanser. But really soaps are very harsh and they're very basic and actually can actually make the skin worse. Also, I want to say that you shouldn't scrub too hard because that's really equivalent of scratching the skin. skin, and that can also cause more inflammation. So I really want to be gentle when they're taking the baths. Now, when they're done, you have them pat dry, but make sure the skin is still damp, and that's when you apply on the moisturizers or any of the topical prescription or cortisone steroid ointments that you have. That's really to help seal in any of the moisture and water that has soaked in with the bath. Now, so this is basically what it can look like, so that you can see a child who's sitting there, and they actually use some blankets or towels and sheets there. So what that can do is to help with the parts of the body that's not submerged on the water to really have it exposed to some of the moisture. Now, bathing is also something that can be a struggle for kids, and so there are more suggestions that Dr. Lebovich had given. So one thing is try toys to see if you can make it a unique, fun time to do. Another suggestion actually is to bathe with your clothes on, so make it fun as if you're going swimming, and it can be a little bit different, and so this novelty can make it more interesting for kids. Also, using some imagery with your children or patients, saying that, you know, the eczema, your skin with eczema is really thirsty and really needs to get a drink. So that's what we're doing when they're taking a bath. Another way that we help with this hydration and moisturization of the skin is with wet wrap therapy. And so here's a picture of a more intensive regimen for kids that are in the hospital. We actually wrap up their entire body with these wet wraps. But there's the concept remains the same, and it can be done much more simply, and it can be done in the home. And so this is a handout that we have in our hospital about wet wraps. And so basically the concept is that you take a bath, like we discussed, and then you put on the moisturizers and the steroid ointments, anti-inflammatory agents that you would, and then you take clothing, so it could be a onesie or a sock, you run it under warm water, and then you wring it until it's just damp, and you put it on, and you put on a dry layer over that. And so the idea is that the dampness from the clothing will seep into the skin to really help moisturize and hydrate the skin. And so that if kids don't like this, then even a few hours can be helpful. So sometimes some parents do that during the daytime and have them do some other distractions while it's on. You do want to keep the room warm so they don't get too cold with these wet wraps. And also it's important to know that this wet wrap therapy, if you have steroids underneath it, it does increase absorption. Other suggestions I've had is that if families or kids are skeptical, that they can try, you know, a small area, so they can take a sock, cut it off, and do it for an arm, and even just do one side first as an experiment, so they can see really what type of effect this has over time. And I mean, wet wraps aren't easy, and I have to say that many families talk about kids who really don't really enjoy or resist doing this. But in our AD center, there actually was one mom who actually journaled her experiences with the wraps for her 8-year-old boy. And it really sort of goes to show the value of being persistent. And so on day 5, lotion, topical cream, face only, applied to the body. Daniel swam at camp today, did not lotion, so he's very dry and scratching hard. He applied the Medisil cream to the face and body, then lotioned head to toe. Wetsuit number 1. Daniel did not like the feel of wet clothes and wanted to take it off. He fell asleep with it on, but soon took it off. I put it back on in the morning, but he had taken off the clothes again. So that's very typical what we see with kids. And you also receive antibiotics for the 3rd time. Day 6, wetsuit number 2. Daniel still did not like the feeling of the wet clothes and wanted to take it off, but he did sleep with it on all night. And then day 7, wetsuit number 3. Daniel is getting used to it and not fighting with it anymore. He does still take off the socks. I think that he's just doesn't want to sleep with the socks. Then persistence pays off. So days 9 through 14. So the routine is setting in. He seems to be less resistant. We continue to lotion twice a day and use both prescribed creams. He's also still taking his antibiotics and drinks plenty of water. We're still giving daily bleach baths and using the wetsuits. Starting to notice positive effects of our hard work and dedication. His itching has ceased to the point of barely noticing or affecting his daily activities. The look and feel of his skin has taken a 180-degree turn. It looks beautiful by our standards and feels so moist and smooth considering. Daniel has really begun to come out of his shell. He's noticed a change in his condition and talks about it with his family. He's so proud of himself for keeping his faith and trust in me. His writing in his summer program is so much better also. So this is the effect that really improving eczema care in general can have. It can actually have effect on the skin and overall in the whole personality of people as their skin does improve. And with the wet wraps, it does really help to be persistent, and the first few days can be more difficult. Okay. So I hope I drove home the importance of moisturizing and hydrating the skin, but I want to now talk about the first of the three I's, itch. So itch and eczema. So this is really a major complaint for patients. It's a key factor in their decreasing quality of life. And we know that AD skin is more twitchy. The nerves in the skin are more likely to fire and send that itch signal to the brain. It can be triggered from anything from inflammation to temperature to sweat. And as the itch occurs, it can have this downward spiral of itch leading to worsening eczema, which leading to more worsening itch. So we really need to break this cycle. We know overall about 60% of eczema patients have itch. 80% will have it during a flare. And there's also this term called nocturnal eczema coined by doctors at Chicago. And it really means this eczema that people have at nighttime where there's this increased itching. And whether it's due to this lack of distractions at nighttime or more exposures to allergens or just natural daily rhythms, there really are some patients who have this worsened eczema at nighttime. And if you see videos of these kids with nocturnal eczema, you see them scratching, they're tossing, turning, they have these restless legs where they're constantly rubbing. In the morning, they wake up with blood on the sheets. And even if they don't wake up in the middle of the night, you can imagine that all this activity really does help, does prevent them from getting a restful sleep. And also, what's really interesting is that there have been increased rates of ADHD for infants who have eczema with sleep disturbances that really haven't been seen in eczema without the sleep disturbances. And this has also been seen with other mental disorders as well. So there's something about sleep and eczema that can have this whole body effect. And what we do know is that eczema is aggravated by scratching, and when you scratch, you cause damage to the skin. But also, this physical act of scratching can release a whole host of allergic chemicals in our skin called cytokines, Th2 cytokines. So ones like IL-4, IL-13, TSLP, among others. And so actually, one of our researchers in our hospital, she works with mouse models of eczema and food allergies. And the way actually she induces food allergies in these mice is that she applies food, in her case, egg protein, to the skin of the mice. But before she does that, she has to shave and tape strip the skin. So tape stripping is where you put tape on the skin and pull it off. So it's essentially the equivalent of scratching. And if she doesn't do that, you don't have that inflammation in place, and you can't really induce food allergies in these mice. So you can get a sense of really the role that scratching plays in eczema and allergy development. So, I mean, when we see kids and patients digging away at the skin, tearing it up, causing this bleeding, naturally, the first thing we want to say to them is stop scratching. But that's probably one of the least helpful bits of advice that we can give, because it's really this deep, intense itch that's really, really hard to stop. And so that if you tell this to them, they may just go to a corner and hide and scratch and then feel guilty for doing this. And so it's something that it really does seem very, very hard to control. I've seen patients come into my clinic where as soon as their clothes come off in the exam room, they just start clawing at themselves. So then how do we treat this itch? So there are a couple of things that can be helpful. So there's antihistamines or other sedatives, but antihistamines really don't have that much effect through its anti-itch properties. It actually is probably more helpful through its effects of sedation. And so it's more helpful to give a sedating antihistamine at nighttime to try to help them sleep. But be careful, because some of these antihistamines can be stimulating and cause kids to have hyperactivity. Moisturizing definitely can help in terms of restoring the barrier. There's cool compresses that can feel good and soothing for kids who have this hot, red, irritated skin. Barrier clothing, so smooth, loose-fitting clothing that can prevent them from scratching. Sometimes you can use gloves on the hands to help them prevent scratching as well. Also, distraction is helpful. So having people occupy their hands by doing some activities, from games to playing instruments, that can be helpful. And then there's also relaxation through guided imagery and deep breathing. And so these techniques can be very helpful in trying to reduce the itching. But really, ultimately, the best way to control the itch is really healing the eczema returning it back into a normal, healthy state. So then now I want to go on and to talk a little bit about infections. And so that one of the major infections bacteria we see is Staph aureus. It is something that really loves to grow in the skin of eczema patients. There's something about the physical characteristics of skin, particularly with lower pH and also with the immune changes in the skin that allows staph to grow abundantly in the skin. And so what we see is that about 5 out of 6 patients with eczema are going to be colonized with staph. And mild patients can have about 80%, 78% of mild patients will have staph, but in the severe patients, almost all of them will have staph colonization. And the staph bacteria in there, they can release all these different types of toxins, staph alpha toxins and other types of toxins, which can also then contribute to the inflammation. And what we do know is with staph is that you can have the superinfection over your eczema, so that when that happens, you typically see this oozing and crusting of the skin, or it can have this red, raw, irritated look with a accompanying skin breakdown. And so for these overt infections, we can do a couple of things. One is using mupirocin, which is a topical prescription bacterial ointment meant for staph, and then you can use that, and that can control milder outbreaks and infections. Then if it's still more severe than that, you can try oral antibiotics, and these are anti-staph antibiotics. Typical ones that we use are cephalexin, dicloxacillin, Bactrim, clindamycin. And if it's still not responding well, then you can consider skin cultures to really check for antibiotic sensitivities to make sure that the staph that's growing there is not resistant. Now, in addition to this overt infection, the bacteria can also play a role through colonization, and as I was saying, as it lives in the skin, it can contribute to the inflammation. So there has been this concept of bleach baths that have become increasingly popular, and the idea is to reduce the numbers of staph that's growing in your skin. And so there was a study done by one of our dermatologists here, Dr. Jennifer Huang, when she was in Chicago, where they had enrolled patients, children, who had moderate to severe eczema, regardless of whether it looked like their skin was infected or not. And all of them started off with 2 weeks of cephalexin, an antibiotic, and they were randomized to receive bleach baths twice a week and nasal mupirocin 5 times a month, or placebo. And then you can see at 1 month, after 1 month, you do already see significant effects between the control group, the blue, versus the red group, which is a treatment group, in terms of the body surface area and severity of the eczema. And then it continued to actually increase over time. So at 3 months, you see that this benefit increase for the treatment group versus the control group. And it's important to note that actually this improvement was only seen in the submerged area of the skin during bathing, so that the face and the hands, the face, if it wasn't submerged, actually wouldn't have this type of improvement. They also did note that actually it was very well tolerated, so even open raw skin that they had for a lot of these patients, none of them really complained of much stinging or burning. So bleach baths, how are they done? So you use typical household bleach. It should be about 6 to 8% sodium hypochlorite. And you take about 1/3 of a cup into a full bathtub, so that's about 40 gallons. That's also about a teaspoon for a baby tub, or 1/2 teaspoon per gallon. And you have them sit in there for 10 minutes time. And then to really to treat the skin of the face, if it's not getting submerged, you can take a washcloth, put it against the face, and have it rest there to try to reduce the staph that's growing in there. And then afterwards, you just like with a regular bath, you have them pat dry and you put on your typical emollients and any of your anti-inflammatory agents. And this can be done twice per month or twice per week to treat eczema. If it's really flaring, you can even do this on a daily basis for a week. Now, other than for bacteria, there's also viruses that can also gain a foothold in eczema. And so one particular one to know about is eczema herpeticum, herpes. And so they are these itchy, painful, fluid-filled vesicles. They occur in these clusters, and they can have these characteristic punched-out lesions. Often people have sort of viral symptoms, so this fever, malaise, this lymphadenopathy. And then there are concerns. If it affects the eyes, it can cause keratoconjunctivitis, which can lead to blindness. It can affect the brain with meningitis or encephalitis, or lungs with pneumonia. And so that if you do suspect that this is going on, it is a medical emergency, and you need to start antiviral treatment right away. All right. Now, going to inflammation, so treatment of inflammation. So that's really the mainstay of treatment is topical steroids. And so there are a whole range of steroid potencies that we see that are available. So it can be ranging from group 1, which is super high potency, to group 7, which is a very low potency steroid. Keep in mind that I also do prefer ointments versus creams versus over lotions. The ointments of the same steroid type will be more potent than a cream, which is more potent than a lotion. Now, the problem that we see with lots of families is the steroid phobia, which can lead to failure to treatment because families can use it less frequently than directed or smaller amounts. It can also be steroid phobia by physicians, where they may be prescribing weaker steroids than that's really needed to control the eczema and leading to continued flaring of their skin. But in terms of steroids, though, it's really hard to have significant side effects from this if you're using this really for short periods of time, for a week or two. We do see that, particularly if you're not using it on the face or thinner areas of the skin. But we do see that the steroid phobia does lead to inadequacy of treatment. And one thing that we do note is that families often don't know how much to use. We prescribe these ointments and creams to families, but then we don't really tell them how much to use. So there's this concept of fingertip units that can be very helpful. So if you measure out the cream or the ointment from the tip of your finger to that first knuckle, that's 1 fingertip unit, and that should cover the equivalent surface area of 2 hands areas. And so this is a good rule of thumb to give to families so they know how much of these they should be using. Now, this is a table that's taken from pediatrics, and it's really an excellent resource. It takes atopic dermatitis management guidelines that were put out by allergists and dermatologists and turns them into practical advice for primary care providers. So it's really a helpful resource, really, for any physician. And so in this table, it deals with acute and maintenance therapy. So first off, that orange section below deals with flares. And the most important point I want to state here is that in general, you do need to use a topical steroids for flares for at least 3 days after the eczema has cleared, because you really want to tamp down any residual inflammation that may be there. There is a tendency to stop early, again, because of this phobia, and so that this can often return to early return of inflammation. Now, there are some patients who do experience regular recurrence of their eczema even when they are appropriately treating their flares. So this is where this green section regarding maintenance therapy is helpful. I do want to note that these are off-label recommendations for topical steroids, but it talks about use of regular steroids for hot spots of eczema. Particularly for the moderate to severe disease. So you can see that for maintenance, it talks about using medium potency topical steroids once to twice weekly. So I usually talk about using on a Saturday and Sunday of the week on the hot spots to help prevent recurrence of this. There's other recommendations there as well, but remember that any of this really should be done under the supervision of a healthcare provider. So now that I want to go into food allergies and eczema. So you've noticed I really haven't talked that much about allergies. And if you actually hear about allergists talk about eczema, they usually devote a large amount of time on how eczema is not typically associated with food allergies. Some of the confusion about this is that we do know that children who have eczema are at increased risk for developing food allergies. But there really isn't that great evidence that foods trigger AD in the majority of cases. And so when you do consider these elimination diets, there are risks that can be associated. So that, one, you can remove foods that may not be clinically relevant. It can lead to nutritional deficiencies. It can also lead to loss of tolerance, so that they now may be more susceptible to having a life-threatening reaction with future exposures. And then there's definitely emotional, social effects of removing these foods from diets of children. So here was a study that looked at milk elimination for AD. And so it was a dermatology center that looked at 186 consecutive patients. And then what they had seen was that actually 1/4 of them had been on a milk elimination diet for the AD. It was prescribed or recommended by their physician 87% of the time. more than half of them didn't have any prior testing, and about a third of them did have a positive IgE to milk. And what they had done was actually reintroduce milk into all of these patients, and of all those, only 2% of the entire group had actually had confirmed milk allergy by food challenge. And those were ones that their milk-specific IgEs were greater than 17.5. So the rest of the children in this study actually had milk introduced in their diet, and on follow-up, they did not have any worsened control of their eczema. This is another study that was done in Denver, where they actually looked at children who were on food elimination diets, 125, and they had started to do these food challenges. And they basically had shown that children who were diagnosed with food allergies, based on testing without a history of prior reaction, most of them were able to pass the food challenge and tolerate the foods without any problems. And there was also concerns of loss of tolerance of food, so that these are foods that were previously in the diet that are no longer tolerated. So again, another study, a retrospective study, this one was done out of Chicago, where they had looked at 132 children who were diagnosed with food-triggered AD by their physician. And of these, 25 had a subsequent development of immediate reactions to food, 19% of them, and 9 of them actually with anaphylaxis. And of this group, what was noted was actually 12 of the patients, 9%, actually were eating the food that they now had now developed allergies to. 7 had milk, 3 had egg, and 2 in other cases. So this is some of the arguments about why we really don't want to remove foods from the diet if possible. Now, this is a case study of a patient that had come to our program for evaluation. So this is a newborn female, born full term, uncomplicated history. And she was diagnosed with eczema by her pediatrician at 2 to 3 months of age. But because of concerns of eczema and a sibling history of food allergies, the physician had sent off testing to foods. And based on those results, was recommended to restrict the following foods: milk, corn, wheat, soy, egg, peanuts, and tree nuts from the diet. And so that she was exclusively breastfed till 6 months of age, but was not provided any milk substitute, and so rarely given watered down juice, but really primarily was drinking water. And then used topical steroids until 6 months of age, but only treated with hydrolamine afterwards, so the eczema probably wasn't even that severe. And so this was the growth chart in the first 6 months of age, so growing appropriately for her age. But then you can see at around 10 months of age, her weight actually had gone down, and actually even the length has decreased. And then at the 15th or 16th month of age, still the weight is really way off the growth chart. So at the 50th, at that time, her weight was corresponding to the 50th percentile for a 7-month-old baby, and her height was at the 50th percentile for a 5-month-old baby. And so, to recap, food restriction diets are often overprescribed. Food-triggered AD is often overdiagnosed, and restrictions can actually create immediate food allergies, even potentially anaphylaxis of foods that were previously tolerated, and these diets can really have harmful effects on a child's growth and nutrition. So in general, how do we handle concerns that are raised by families about food allergies with eczema? So one, we can repair the barrier, which can lessen the chance of IgE sensitization with children. The second is that, well, there were studies, a study had shown that actually if you're able to improve the eczema of the child, the concerns for food allergies are alleviated for parents, so that before treatment was ensued, they asked parents what is their concerns about food allergies, and they would rate them on average a 7.7 on a scale of 10. But after effective management was in place without any food allergy restrictions, their concern went down significantly. So if we can address the eczema really at its heart, at its core, then we can alleviate some of these concerns by families. And so our guidelines from our allergists, we have a practice parameter that states that in children less than 5 years of old with moderate to severe atopic dermatitis, evaluation of food allergy to milk, egg, peanut, wheat nut, and soy could be considered if a child has persistent AD in spite of optimized management and therapy. And so this is really a treatment approach that we can consider. And so let me just finish up in the last couple of minutes about understanding the rationale for early peanut introduction. So you must have heard in the news about really the idea of trying to introduce peanuts in early. And so just wanted to go over why this all came about, this change. It began with this really first observation in Israel that they had a very low incidence of peanut, about 0.04%. And when they compared this to a control group in the United Kingdom, it was actually 10 times lower. And what they noticed is the difference is that actually peanuts were introduced very early in Israel in the form of this food called bamba, which is basically looks like a cheese dough, but is contained of peanut protein. So the idea was that early introduction of peanuts can help prevent development of peanut allergy subsequently. And so there was this large-scale prospective study done in UK looking at infants with severe eczema or egg allergies. And then they had screened them with peanut skin testing and then randomized them to either introduce peanuts in early on or avoid peanuts. And then so at 6 months of age, they were evaluated to see whether they had a peanut allergy. And what they noticed with actually I'll skip to the overall, is actually overall, if they were able to introduce peanuts in at the newborn, at the 6 months age and keep it in until 60 months, you had an 80% reduction of peanut allergies in those kids. So this really is where the basis of trying to introduce peanuts in early on came about for kids with moderate to severe eczema. Now, putting it all together, so it's important when you're talking about eczema and management plans that you have a written plan for them, because the names of the ointments can be confusing if you particularly have more than one type. So they really need to know when and where to use them. And it can be these plans that you can download from sites, or you can even just write them out on a piece of paper. And then for flares, then I actually have something which I call boot camp, which actually I took from Sheila McGinnis, who was a dermatologist at our hospital. And it's a written plan for flares that we use for 1 to 2 weeks' time, and then really is a comprehensive treatment approach where you have bleach baths, topical steroids, moisturizers, this wet wrap or wet pajama therapy, use of antihistamines if it's helpful for itch and sedation, and antibiotics if there's any signs of infection. And then if families really can use this comprehensive approach, and I see them back in 1 to 2 weeks time for follow-up, you typically see significant improvement of their skin. So just want to remind everyone that it's really important to keep in mind the core principles of itch, inflammation, infection, making sure that all of those are being addressed in your kids with eczema. And then really at the core of all this is to moisturize and hydrate the skin. Thank you.
Well, thank you so much, Dr. Lee. I appreciate everything that you've had to say. I especially really like the part where you talked about children putting the lotion on themselves. I think that's so important to empower kids wherever you can. We do have a few questions for you today. Our first one is, does Vaseline help? This is a school nurse who says that's all that they have in the school health office. And can you recommend something over the counter for this?
So yeah, so Vaseline actually is a very typical one. So petrolatum jelly. So that's one of the standard types of moisturizers you use. And actually, it's an ointment, so actually it really has no water content. So that actually can be very helpful for eczema. The biggest issue is that it may not be well tolerated for some kids because of the feeling, like greasy feeling or the prickly sensation that kids feel with that. But that's a perfectly fine one to use.
Sounds good. Someone wrote in wanting to be sure that you are aware that most school nurses will need a doctor's order to prescribe any kind of lotion at school, even if it's an over-the-counter ointment, cream, or lotion. Basically, they're saying that the parent would have to supply the treatment, and we would need to have a doctor's order. So basically, that's one of the challenges that we certainly see in the school health office.
Right. Yeah, that's a good point because yeah, for any of even the over-the-counter prescriptions, I do have to write those forms for schools, so that's a good reminder.
Well, yes, and in many schools, you need orders for absolutely everything, even including things like sunscreen. So it is a challenge for nurses who want to be there and want to be helpful, but we certainly need all sorts of orders. So someone is asking the question, which antihistamines are better for a 2-year-old toddler?
So when I'm talking about antihistamines, it really is the sedating ones that seem to have the best effect. So you can use something as simple as diphenhydramine, the brand name is Benadryl. There's also over prescription ones, hydroxyzine, which also can be helpful in terms of the sedative effect of these antihistamines. Those are the ones I tend to use for patients to help with their itch.
And I would think that when they're talking about someone as young as 2, that they would want to talk to the physician about what kind of a dosage to use.
Right, right. And both of those can be used for children that age, but you definitely want to make sure it's an appropriate dose, and it's generally dosed by their weight.
Okay, great. Okay, this is another question. You mentioned no cleansers or mild cleansers during bathing. What do you recommend a family uses?
So you don't, for the most part, kids don't need a cleanser. Water is enough to really clean off any of the dirt that accumulates over the skin. But if you do have a cleanser, actually the one that I do like actually is very simple, is actually a Dove moisturizing bar, which is easy to get, so nothing too fancy, but it is not a soap, so it's not basic, and it is something that we have had good effects with.
Okay, another question. Where can you get one of those action plans to use in the office?
So the one plan that I had up there was from the Quad AI, and so that if you go to their website, you should be able to download one. The other one was from our hospital, where it was just a plan that one of our allergists actually had made for us to use. So it's modeled similar to the asthma action plan, so that it's pretty easy to make up a own plan for your own practice.
That's great. The next one isn't a question. Someone's just offering. This is really good information. So next one is, what is the maximum strength of steroid we can use for eczema on the face or the genital area?
So that probably differs depending on your provider. But I'd have to defer that to talk to your provider. I can say that in general, for the face at least, I'm okay with using a 2.5% hydrocortisone ointment. In some cases, I've had use stronger ones for shorter periods of time. But you're right that for the face and genital area where there can be increased absorption and thinner skin, you are more worried about side effects.
Okay. Do you recommend I can't even say this day, bleach baths for someone with asthma as well as eczema?
Interesting. I've never seen a study with asthma for bleach baths. It really is meant for the staph that's growing in the skin. I don't think that there would be any direct benefit for kids with asthma unless they also have eczema. Those bleach baths, though, do seem to be also helpful for mild eczema, so it doesn't have to be really red, raw, or irritated. So even if it's mild eczema that may be flaring a little bit, you can use those bleach baths.
Do you think the bleach would bother a child with asthma?
I actually don't, because actually the amount of bleach that's put into there is equivalent to what's in a swimming pool, the chlorine in there, and so that actually a lot of our patients who have asthma can swim, and they usually don't have problems with swimming. So if they don't have issues with swimming, then these bleach baths really shouldn't cause them a problem either.
Good to know. Do you have any sunscreen and shampoo recommendations for children with eczema?
Well, I can name some name brands that we use, but I don't really endorse anyone specifically. But there's Vanity Cream, which is one that makes a whole range of cleansers and soaps and sunscreens. Neutrogena is another one that we recommend. And in general, for sunscreens, we want to use something that's titanium oxide based versus other chemicals, because those can be more sensitizing. So if you look at the ingredient label for sunscreens, you really want to see something that's, again, this titanium oxide based product.
Okay, we're going to have time for just a couple more questions. One is there any benefit to applying an ointment over the cream to seal the cream in?
If you are using a ointment over like a steroid cream, is that what the question is, or?
The question was would the cream basically seal in the moisture with the ointment with the lotion?
Well, creams can do some job in sealing in the moisture, so you can use that. I mean, if you can use the ointment, then that better. If you want to use both, and perhaps if you mix it in, then that would reduce the overall water content. So I guess that actually would have a better effect than just using the cream alone.
Okay, and our last question is going to be, can tea tree oil prevent the staph infection?
So actually, I don't know much about tea tree oil, but I know families use these oils to help with infections and inflammation. Some of them do have anti-inflammatory properties and antibacterial properties that can be helpful, but it's also possible that any of these natural products can actually cause more inflammation because it really is a foreign agents that you're applying to the skin, so it's possible that any of those can trigger it. So if you use anything that's natural based oils, that I would always suggest trying it on a small area first before you apply it to the entire body.
Okay, well, thank you so much, Dr. Lee, and I'd like to thank our audience for listening today. Allergy and Asthma Network is always offering new things, and we have a new resource that we're offering to you. It's a 3 to 5 minute video post of our popular Ask the Allergist series. On our website, under News and Views, click on Ask the Allergist. Last month's question was on how your weight affects asthma, and this week we're releasing a post on new advances in food allergy management. Please join us next month for our March webinar, tentatively scheduled for March 23rd. Details and our topic will be announced next week. You can register for this webinar on our website at allergyasthmanetwork.org. Look for education in the horizontal navigational bar near the top of the page and scroll to webinars. You can also view our archived webinars on this page for our website. Please visit our website for quality guidelines-based resources on allergy and asthma. Also access important medical information on allergies and asthma from our partners, the American College of Allergy, Asthma, and Immunology at allergyandasthmarelief.org. Thank you again for joining us, and we look forward to having you register to be with us the next time on Advances in Allergy and Asthma. This is Sally Schessler for the staff at Allergy and Asthma Network. We wish you a great and healthy day as we work to breathe better together.